Hi there. My name's John Waits. I'm a family physician and CEO of Cahaba Medical Care, the residency director of the Cahaba UAB Family Medicine Residency. Over the course of the talk, we'll introduce each of ourselves and our organization a little bit, kind of interwoven into the talk. We're going to start with a video, but Jeremy, I'll let you introduce yourself.
Yeah, Jeremy Kreider. Thanks for being here. I'm a family physician as well and oversee a lot of our family medicine residency training programs, specifically in Birmingham, Alabama. We have a lot of residents, which is why we're here to talk to you today about having lots of different sites and multiple campuses. So happy to be here. Thank you for being here.
I'm going to see how this works. Let me know if you can hear it in the back.
That's my granddaddy, and that's his buddies. I never have figured out whether they were just clowning around or whether that was their Sunday best. I'm not going to retire. I have 4 granddaughters I have to get educated, and so I'll be working for another 30, maybe 40 more years, the way I figure it. I'm still in that stage now where I'll put in probably 12, maybe 13 hours a day where I'm actually here at the office or in the emergency room or the hospital. I'm just an eternal optimist. I'm saying this is the best place in the world for a doctor. You just give me somebody that likes to do a little fishing and hunting and likes the outdoors and would like for he or she to have more than a modicum of intelligence and durability, and we can make it go. We're going to keep that hospital open no matter what it takes.
I used to make more house calls because we weren't so busy in the office. So I would set aside from about 2 in the afternoon and circle around. How you doing?
Hello, ma'am. How are you?
Do you remember the day when you came in when you were bleeding so bad and you went to the hospital?
Helicopter and all.
Right, they flew you because you almost died on us. Did you know that? You were saying you were about ready to say goodbye.
Yeah. I don't remember.
No, I didn't think you would remember.
No, I don't.
I will promise to come back with a shot. How's that?
Okay.
Okay?
Yeah.
All right.
You know where I live there, though. You know where I live.
I know where you live at.
Well, the University of Alabama made that video. The communications department worked with the College of Community Health Sciences and the Rural Health Department. They made that video back in 2010. I was on faculty there as program director at the Tuscaloosa Family Medicine Residency then. That's not the video that inspired me to go into rural medicine. Back when I was a medical student, there was a very similar presentation at the Family Medicine Interest Group of two doctors that had decided to go help Pickens County on the Mississippi border reopen their labor and delivery. And over a 10-year period of time that they were practicing, they took the infant mortality rate from about 17 down to about 7, which was double the state average to lower than the state average. And kind of my story, I shared a little bit of this morning. This isn't the main part of this talk, but I felt called into medical missions and even interviewed with the International Mission Board for a few years and went to rural Bibb County to pay off some loans. And over the course of being there, beginning to teach at the University of Alabama and building a rural training track in Bibb County, and hearing stories like this, I realized that there is a mission field right in front of me with my patients. And I've been in Bibb County for about 23 years now. So I promised you we'd introduce ourselves and our organization. We are from Cahaba Medical Care in central Alabama. Bibb County is here. Perry, Chilton, Wilcox County, 4 rural counties that we have the pleasure of serving in. And we'll tell you some stories about some of those communities. And you'll notice the greater Birmingham area here, about half the organization, about 3/5 of the organization is in the west side of Birmingham. And we'd like to talk about what it's like leading a group of residents and a group of clinics in some geographically dispersed areas. We have a training program, the Cahaba UAB Family Medicine Residency. There are 2 rural tracks and 2 urban tracks. So about half of the residents match into some rural counties. They're in Centerville, they're in Perry and Wilcox, and then half of the residents match into our Birmingham tracks. Each of these locations have different track directors. You see Dr. Kreider there is going to talk a little bit about some of our Birmingham experience. We also have other training programs, nurse practitioner residency, pharmacy, behavioral health training, and a new psychiatry residency that's in our rural community. Dr. Kreider.
Yeah, so let me just kind of give you the outline. I've already introduced myself. I've been in academic family medicine for roughly 15 or so years and led a residency in Memphis for a little bit and then came down, and we'll talk a little bit about what that looked like to be grafted in, to become part of an expanding primary care underserved training footprint. But some of the things that we'll talk about, if you're in this room and you're nerdy enough to be here, you probably already realize that there is a need for expanding training in underserved communities. We'll talk a little bit about how do you build and maintain culture as you have multiple training sites. And if you're thinking about should you expand, should you enhance your training footprint, how do you discern where you might go and how you might do it, or if you should even do it? What are some of the common pitfalls that come up when you're expanding? And then how do you maintain high quality education across your different sites? And then at the end, hopefully we'll have some valuable Q&A, because I feel like this is a little bit more of a technical topic. So that would be really great if y'all had some questions. But if you want to get out your phones and take a shot here, a little Slido. This is a question asking, what is your role in your organization? If you are in an organization, maybe you're a student, that's great too. Maybe you're a 6-month-old, that's really great. Do you already have geographically dispersed campuses, or are you contemplating? So this is gonna, so scan this and then just, it'll be free text. So scan and free text, if you will, just so we have an idea of who's out there. I love that you students are getting an early jump on expanding the primary care training network. So this is great. It makes me feel good about our future. Y'all can all see these as they're coming up. Some program directors, CMOs, future APD, even yeah. Have expanded. Okay. 3 sites, 2 hours or more apart. Awesome. Come up here and join us. 3 campuses in 1 county, 1 campus, but thinking about more. Okay, great. So we can commiserate with some of y'all. All right. So this is just is helpful for us to tailor maybe some things that we say. If you came in here with anything that you really were hoping to get out of this, would you just drop it in? That way we can tweak it. If you didn't, that's great too. We won't spend too long here, but
We've got about 2,000 slides here. We can route to whichever way.
yeah, that's right. It's the master of many slides. And as we're going along, if you want to flag us down and stop us and add any comments in or ask any questions, please do so. Yeah, what makes rural unique? Graduate retention, being approached by a hospital, start family medicine residency, culture building, just starting 1 residency campus, have many rural areas nearby that need care as well. Yeah, difficulties of the PCP in a rural county, specialized care, family medicine, yeah. Stop reading these. Working and living. Yeah. Yep. Wow. I actually thought there might be like 4 or 5. So thank y'all so much. This is affirming. All right. Criteria for how to decide where you locate your rural residency.
All right. Well, just a little bit more about our story and our location to give some context. I've mentioned I've been in Bibb County for about 23 years. I worked for the hospital for about 6 months. And when I decided that I was not going to leave the county, a opportunity on the mission field fell apart, and I realized I enjoyed taking care of my patients, and it would take a generation to make a sustained difference in the social determinants of health there. I opened a private practice. I had no idea what I was doing, turned it into a rural health clinic. If you're for the students in the room, there is a website that's interesting to noodle around, data.hrsa.gov. And you're able to look at the low-income population, the people who are twice the federal poverty level. So the IRS defines poverty, low income is 2 times that. And when I started this practice, less than 7% of the low income population had affordable access to primary care. A few years later, one of my residents, Dr. Lacey Smith, joined, and we took our practice and turned it into a 501c3 nonprofit, which meant for us is that we gave away our practice to 9 community members that we trusted to be our board of directors. And we've grown with them, and some of them have turned over. And we also, we had started teaching. We had residents coming down from Tuscaloosa at the time. And, in relationships, so I've been in rural, as I said, for all of this time. And if you've been in rural for a little while, you realize universities come, universities go, outside hospitals come, and this is one of the things that happened to us. And so we had a dean change, and they sunset this rural track that we had, and we were providentially in the right place at the right time. And there was a program called the Teaching Health Center program, and we decided to start our own family medicine residency in Bibb County. And we here is some of our early diagrams trying to explain where in the world this 444 program was. We matched 4 residents and had a couple of other faculty people that we had known from the past join here. Say, we heard you're opening a family medicine residency. They joined. Here's our first class that's joined us. One of them is still with us. Dr. Andrea White is our assistant chief medical medical officer. And over the course of the next few years, as we had more and more residents, we had another physician in town that wanted to, in the county, that wanted to join us. Another invitation from a rural community that wanted us to open a new access point, an FQHC there. Dr. Ballard, a rural medical scholar, Dr. Lauren Lincoln, came and was interviewing to be another faculty member in Centerville. And at that time, this was a major pivot point in our organization. We were looking for our 4 rural family medicine residents. We needed an ICU rotation. We needed an OB rotation. And so me and Lacey I'd been at this point in rural medicine for about a decade, and she had been there for 3 or 4 years. And CEO of the hospital in Bessemer, Alabama, which is in the city, in the greater Birmingham area, said, we would love to have your residents. We don't have an FQHC here. We hear you're an FQHC. We have a revolving door of uninsured patients, Medicaid patients. Would you come and set up a clinic here? And I thought, well, Lord, you've already changed. I thought I was going to be in Jember, Indonesia. Now I've identified as a rural physician. We've opened a couple of rural clinics. I have no vision whatsoever of going to Birmingham. What are we doing in Bessemer? I thought, well, this is going to help our rural track. So I said, Lauren, we got a wonderful plan for your life. So Lauren, who thought we did a bait and switch on her. She thought she was interviewing, and again, she was a rural medical scholar at the University of Alabama. She came, helped us open a practice in Bessemer. This has grown to the 3rd floor of this multi-specialty building here because that CEO of the hospital was right. We have found the uninsured patients, the Medicaid patients, a bilingual population. Lauren is bilingual and has helped grow that practice. And before long, the Jefferson County Commission, Jefferson County is the county that Birmingham is in, said, now listen, we heard that you're an FQHC in Bessemer. We've got this empty 22,000 square foot building that the health department vacated a decade ago. Can y'all do something with it? And so we had a PA in Bibb County who said, if you ever have a job in Birmingham, put me there. I'm like, well, so we renovated 3 exam rooms on the back end of this building, got her started. And then as soon as we open it, I find out one of our chief residents, her grandparents live in West End. She went to the West End High School. This is the West End of Birmingham. So it's like, this is perfect. This is God ordained. We're going to bring her there as a OBGYN in Inslee that wanted to merge with us. And so we, at this point, UAB was thinking about reopening their family medicine residency. And we said, well, let's make a really creative partnership. We'll open a family medicine residency with you. And so we started that work 2017, 2018. And I began to notice something. So in that West End clinic on Wednesday mornings, I saw patients with our physician assistant, and I was kind of blown away. So at this point, I've been in practice for about 13 or 14 years in rural Bibb County. And there was more, the gratitude of the patients in 35211 in Birmingham, of us opening a clinic there. It felt like I was in small town Alabama. And I was trying to figure this out, and I realized Birmingham's made up of about 95 different neighborhoods. And at the neighborhood level, as I got to know the neighborhood leaders, they were just so grateful to it there. It felt there was more in common with rural America, with rural Alabama, than there was different. Remember that 7% of the low-income population in Bibb County that had affordable access to primary care? This is the greater Birmingham area. All of these zip codes that I've not highlighted in a particular color had less than 10% of affordable access to primary care. There are 3 zip codes in downtown that had 10, 11, 15% respectively. So it was around 2 to 6%. This was shocking to me. And so it's December 26, 2017. Lacey was stalking her emails, and what was going on in your life at that time, sir?
Yeah, so little old Cahaba, just kind of doing its thing, minding its own business in the country. And then there's this organization called Resurrection Health, and the CEO is Rick Donlin, and You may have heard of him. He's kind of loud and obnoxious, and he has a lot of opinions. And so did our organization, Res Health. We were loud and obnoxious, and we have a lot of opinions. But dadgummit, we ran out of money, and we closed around Christmas time. So around Christmas time of 2017, I remember myself and John David Williamson kind of gathering up all the residents and saying, "Hey, I hope you have a great Christmas break, because when you come back, we're all out of jobs." And that was a pretty terrible time. And then I hopped in the car, and my family was going south to Louisiana for Christmas break, and I'm like at a gas pump somewhere in Mississippi, and John calls, and he's like, "Hey, I heard you guys are closing. Really hate it for you. This is terrible. And also, we've got this huge space on the west side of Birmingham. So if you guys ever wanted to think about, doing something here." So I guess in the many ways that you might think of like expanding to somewhere else, you could always look for like somebody that's down and out that needs a partnership. So this would be one model. So that's how we grew our educational footprint into the urban space. And so we spent a lot of time in prayer and discernment trying to decide, okay, like what are we going to do? And so ultimately, though, we sensed a call to go to Cahaba, and 6 residents and 5 of our faculty members went down and started the urban campus, and that's how that got started. And again, we're loud, we have big personality, like that's kind of our thing. Cahaba, very small, introverted, not small actually, but introverted and quiet. And so what could go wrong, right? More to come about that in a minute. But we came in there thinking, oh, well, we're just gonna kind of reboot what we were doing, right? It's gonna go fine. We're just gonna keep doing what we're doing in a different city. That's a lot like people in here have spouses that are on this slide that are a lot like what we're doing back there. But in the meantime,
I've got some really quiet people. And as the CEO, my 360 eval from Casey Hicks, my newly minted Global Health Fellowship Director, and Lauren Lincoln, that I've convinced to move to Bessemer, and Ernestine Clements, that is just in the news, one of my chief residents that's now in West End, and she's coming home to her practice, and we had a particular culture, identity, and I'm thinking, how am I going to merge these two different cultures together? Let me show you just another video clip about Dr. Ernestine Clements to give you a little taste of what was happening in 2017, early 2018, and then I'll come back to this part of the story and talking about marrying cultures together.
In this particular community, we're worried about, can I put food on the table? Can I pay the light bill? Do I have a roof over my head? So medicine comes last. That was one of the things growing up that I dealt with. My mom dealt with addiction, but I think the challenges that I had growing up with her definitely make me a better provider, specifically for a community such as this, because that's where I'm from. We are a federally qualified health center, which allows us to make sure that folks have access to care. Justin, to me, represents so much of the struggle that happens in this community, and how a lot of our folks get trapped in this downward struggle, this downward spiral. Justin has been in and out of jail, been dealing with heroin dependence, but hopefully being here, he has the light to find his way out.
When I first started coming here, I didn't want to talk. I had to build my trust with them. They've been working with me for a while, and it's been tough with the pandemic stuff going on. It's kind of stressful. It messed with me. So when I talked to Dr. Clemens and Miss Charity, they get to know you so they can know how to work with you.
And you would qualify for different programs to be, live there in transitional housing for free until you can get a job and get up on your feet. That's how it works.
That's good.
Yeah,
I need
yeah.
that help. They saw something bigger in me, not no drug addict. They saw a person. Justin, he saw me. And they helped me out to guide me through the ropes that I need to get through. With my mental stage, I had them thoughts like, I'm not worth nothing. I'm a drug addict. I had them thoughts of that, being that. And when I talk to them, they don't see that in me. They see more. Like, they see I'm going to be better one day. They see I'm being better now. Like, it's a lot. Just to hear that from them.
Loving what you do definitely plays a big part in coming back every day. Loving on the people that you serve, showing them that, hey, we're here because we love you and we want to make sure you're happy, you're thriving.
So that's an example of some of the stories that were happening on people that were working with me and Lacey and that I'd recruited. And so Sharon Lavoie is one of my executive coaches. She had come to our leadership team and done a bunch of different things. And I said, Sharon, got this loud group from Memphis that I know and love. I'd known Rick, and Lacey and I had journeyed up to, we'd taken a pilgrimage up to Christ Community back in the day when we were first starting, and knew John David, and so we'd all been close. So we had that going for us. But I said, this is the only two mergers that we had done were two solo physicians that just kind of joined into the practice. And so she spent a couple of months walking me through this book. I recommend it to you if you're going through any major change in your organization, Managing Transitions. I think it's in its like fourth edition. And so one of the things that we talked about that she said that was really insightful is that each group needed to have space to grieve for what was lost. And I sort of intuited that for the resurrection crew. It was a whirlwind tour for me and Lacey to try to get everything ready and inherit 11 docs and hire the 40 or 50 people is going to take to get that up in 6 months. But in their life, this was upended turmoil. In a matter of weeks, you're moving to another state, and so I instantly understood that. What wasn't completely obvious is that Ernestine Clements, Jen Platt, Casey Hicks, Lauren Lincoln, my rural residents, the identity of our organization as rural, and we got a couple of satellite clinics in urban, and this was, we kind of balanced out urban and rural over a 3 or 4 month period, and there was a period of grieving and acclimation, and so that was kind of our part of the merger, and me sort of facilitating all of those conversations. If I had it to do over, I would definitely do it better, but that was really helpful coaching and advice on my end.
And on my end, so I'm representing the perspective of maybe some new folks that are joining your organizations that you're growing into. So we, like I said earlier, we had a very different kind of cultural background. And so one of the most helpful things that happened was John was like, hey, shut up and read this book. Didn't exactly say it like that, but basically, this is super helpful for folks that are coming into the organization. And it really is encouraging humility and curiosity, taking 90-day period when you're first getting started to learn. So a big part of my job in those first 90 days, I felt like was just not being like a rejected transplant organ. Like we're so different. I could see that. How do we not like sabotage this? And so a lot of it, great tips in this, just meet people, ask questions, be curious, don't give your opinions, to just take copious notes and understand what's important to the organization. What are its priorities? And how do I fit in here? And so, made a lot of notes, didn't do anything to shoot ourselves in the foot too bad. incredibly helpful book.
Well, at this point in the John and Jeremy show, another quiet partner, Dr. Lacey Smith, that I mentioned before, so we've gone from one team to 6 teams in 5 different cities. No one clinic does things the same way. You've got to do something about the culture here, or we're going to lose what we had. And I'm thinking, well, I thought that's what I was working on, is the culture, but I really didn't understand what culture meant. Culture is something that like you can sniff it out, it's there. When you walk into Disney World, there's a culture. When you walk into a good restaurant, okay, the vibe is right. A church, every organization, whether by design or accident, has a specific culture. And the issue is, are you going to build a culture? I did a lot of reading, found this series of books about building a culture by a guy named David Friedman. And so I embarked on this summer of 2018 journey of sort of building this out. What is our culture going to be? Yes, we were a faith-based organization from the moment I opened the private practice. And when we went through the federally qualified health clinic process, we instantiated that into our bylaws. We had a federal audit. And so yes, we were following Christ in serving and loving people. But I came to understand that there's more to culture that has to be built out. It doesn't magically happen. Look at our churches. Churches, cultures can fall apart without intentional thought process and leadership. And so, stealing from this book, and this book, the way the book goes, it encourages you to build behaviorally specific, more than just a one-word value, behaviorally specific thing. So I'm going to share a couple of these with you. We have 40 of them. I won't read them all to you, but they're about leadership and communication and community and just work ethic and habits. And they're things like do what's best for the patient, even when it's hard, unpleasant, or to our own detriment. Make decisions that reflect a reverence for long-term relationships. Serve as unto the Lord, Matthew 25:40. And I tell our employees on day one, if this is not your faith tradition, that's okay. You're in the right place. I want to introduce you to a man named Jesus that we follow. And it's why a lot of us show up to work every day. And he said something like this: I tell you this, you did all of these things to help other people. They were not important people, but they were my friends. When you helped them, you also helped me. And so when you look around and see our physicians, our residents, our nurses, you serving in this way is one of our greatest assets. That's what we're here doing as a company. We check our ego at the door, and we work skillfully. Everything we touch has our signature signed in bold ink. We do the right thing always. And it's sort of at this point that in this merging of culture and trying to build a joint culture, started thinking. Jeremy and I had a long walk one day in Birmingham in his neighborhood. I talked to a couple other people in the organization, 5 or 6 people that I really trusted. Started thinking, wait a minute, is this milk or meat? What's really happening here? Are we taking the kingdom by storm? Are we changing healthcare disparities in rural Alabama? Are we going to change the fabric of inner city Birmingham? And I thought about that, and I kind of doubled down on what it meant to have a lowest common denominator culture. And we were employing medical assistants and receptionists that maybe maybe in their first job, or maybe for the first time in their life, an employer or somebody in authority said, we expect each other to do the right thing. And, if you make a mistake, it's all right. We need to apologize. And then it gets deeper. We always give people the benefit of the doubt, hearing the best possible interpretation of others' words. And we talk about respect and not forgetting that impact is not the same as intent. And, as the pandemic came, and as the George Floyd moment happened, we were really able to fall back to the level of the lowest common denominator culture and be able to have a conversation as we sought to serve, as things have gotten so polarized lately. So.
Yeah, just double click all the important work for the C4s that we did. And then this is relevant for us as CCHF. How do you maintain your faith culture at different sites as you're bringing in new people, bringing new sites online? How do you do that? And we were kind of coming from the same but different sort of backgrounds. And that was, we said, well, we need to have some kind of spiritual curriculum that we build into our family medicine residency and other training programs that we do. So we were able to build that out. We're on like version 4 of that. We are sort of a pluralistic residency program. We have people that are coming from all different faith backgrounds. And so it's actually been a really fun adventure to come alongside folks that are not really understanding entirely, like, well, why are we having a sort of Christian themed spiritual didactic time? Why do we have to do that? And it's fun to have those conversations. And whenever you're able to really spend time talking people through those, my experience has always been that people have kind of left the residency, I think, closer to the Lord than when they came in, and it's always gone really nicely. But we can talk more about what our spiritual didactics look like, but I'll just mention that part too.
Brother. Okay. Dr. Sumter Blackman, just finishing out a few stories that we started with as we start to, we're about 25 miles away from the airport here. We'll stick the landing in a second. Dr. Sumter Blackman eventually became the only physician left in Wilcox County. And as we were starting our second rural track, our frontier track, I found him. I had known him from this documentary in 2010. I had the chance to meet him. And he said, "John, y'all are the partners we've been looking for 25 years. Let me just give you my practice." So he gave us his building. He said, "Just employ my people, employ me." You heard him say he's going to practice for another 30 years. He may. He has learned how to use an electronic medical record now. So I don't want to hear any complaining from you students in the room. Josh Bro just graduated last year from our frontier track, Michael McNabney from our urban track, and have the county got down to one physician. They got cited in the Boston Globe and last summer, and I said, "You're out of date. By September, you'll be out of date." We've got folks coming in, so there they are. We've had graduates from Bibb County. From our rural track stay, we've been able to open other clinics in other municipalities there. We've had some urban residents graduate and work at an urban clinic, but say, "I want to spend a couple of days a week in rural places." We've had some of our graduates say, "I know there's no more room in the West End Clinic. Can you open us up another practice?" And so we've done some of that. And it started to make a real difference in the Birmingham community. These zip codes are at about the 20 to 30% impact on the low income population. And you'll see Christ Health on the east side. Robert Record's given a plenary on Saturday. And so, some outcomes there. Faculty development.
Yeah, so how do you maintain a strong, how do you maintain a strong educational environment when you're expanding to multiple different sites and you've got faculty that maybe are brand new or they have not been in your organization? How does that work out? And so I think you have to kind of build your own sort of bespoke faculty development program, which is what we've done. It's called FENCE because everything in our ecosystem has rural farm-based acronyms. But we have a 24-month recurring.
I didn't put in the AI-generated slide with you with no shirt on. So
yeah, thank you for that. Yeah, thank you, Farmer Jeremy. So we have a 24-month recurring faculty development curriculum, and this is some of the topics that we utilize. And really just had to do a lot of work in building a faculty handbook. What does it look like to evaluate here? What does it look like to be an advisor here? So on and so forth. Put a lot of those things together, try to standardize them, go through that over and over again. Just coming up with some kind of mentorship system. Your more seasoned faculty members that come alongside the newbies and try to teach them. And we all get immersed into the leadership mind of John Waits, and has a lot to do with difficult dialogue and the cultural competencies and Myers-Briggs, and everybody kind of has a shared understanding of some of the leadership and the way that we communicate and get along here, kind of things. So those are really our prepared remarks. We have a few minutes for any kind of questions, and then there's also, don't forget, a survey too. But yeah, would love to hear who has a question for us or some of the other folks that are out there that have been expanding into multiple sites. Hey, Dave.
I don't know that any of it is easy. Yeah. So I'll go back to once we wrote out our culture into those 40 behaviors, and again, if you read those books, you'll see that we almost had a pretty close model fidelity. So one leader in the organization sends an email each week highlighting one of those behaviors, and just it's almost a shared group emotional intelligence constitution that we have. And somebody writes, and we focus on one for the week. And so, of course, people miss their email. And so the kind of opening moment of every meeting is talking about, what was your insights from that email. And when this is done the best, somebody like prompts with a question for the week, or what sort of discussion question we're having for the week. And I meet, I have a full day with our new hires, and we go through a little history of the organization, but we spend all day, we go through every one of those, and I have these interactive quizzes, even games, and question, a little workbook that we go through. And then at the 1 year mark, every employee in the organization goes through a full day, essentially a crucial conversation style course, and we recirculate some of that. And so there's a bunch of stuff that's sort of invisible but not invisible that just continues to nail it down and give us that socialized and shared language. And the residents are included in all of that. So I haven't left it with the residents or the faculty. I really engage with kind of every person that comes in to the organization. So, yeah. Yes. Yeah, so UAB is awesome. We started our rural residency in 2013. Took us 3 rounds of accreditation. Back then, it took us, the ACGME didn't know what they were doing with small rural programs. They do now. So we had 3 rounds with them from 2011 to 2013. We got accredited, and Tuscaloosa was supposed to be our ICU and OB rotations, and then that fell apart. And so there I am in 2014. And we were accredited, we were funded, and so our relationship with UAB started on the perfect foot, because we didn't need any money, and we didn't need them to do anything for us except let some rural, it made them look really good right at first, and we were small, and then conveniently for us, UAB closed their family medicine residency in 1999. And there was some strategic planning in 2015 where they wanted to reopen. And so we were involved in all those conversations from 2016, 2017. And I kind of glazed over it. But, the urban track is basically where Resurrection came and joined the West End. But that Highlands track, and it's on the UAB campus. It's been a joint venture between us and UAB. But it's sponsored and funded by Cahaba and accredited by Cahaba. And so it's been a great relationship. They have us on as adjunct faculty, and it's really been a symbiotic relationship, kind of the best of both worlds. So our residents, even the rural residents, have access to stuff on the academic campus, and but there's a little bit of a firewall between a lot of the university politics and everything. So. Yes. Yeah. So we have 46 physicians. Every single physician has a different clinical schedule, different administrative schedule, different faculty involvement. It really has been, I know there's a simultaneous talk going on about burnout, and really one key component, not the only one, but one key component that Lacey and I have had of trying to reduce physician burnout is just, we've built this robust scheduling team that gives everybody the deal that they want, and we hard-nosed say, okay, the deal that you want, this is what we can afford to pay you for the deal that you want. And then we figure out how it fits. So people teach as much as they want, teach as little as they want. We do have a basement of like, this is a teaching institution, so you're going to have a student rotate with you, but not everybody is involved in precepting if they don't want to be, if they want to be really more private practice flavored. And there's some track directors who are very involved in faculty development, curriculum creation, like Jeremy, and hope that answers. But it really is that nuanced. Yeah. Yes. Are you talking about the faith aspect mainly, or? Yep. Yeah. Well, two things to say, I think. When we started, we were, it was a rural health clinic before we became a FQHC, and it was just, I hung a shingle in a small town, and it honestly, so I'm a graduate in His Image, so I went to a Christian program that was basically had a tax ID status like a church. I had a certificate of ordination at graduation, but when I opened a practice, it didn't cross my mind that I wanted to recreate exactly what I had in His Image. It was a faith-based clinic, and I never asked an MA or a receptionist if they were a Christian before they started. It's just like, but they're expected to have this. I mean, I didn't think about culture in these ways. It was just like, it's a 2,000 square foot building. We're just doing clinic, And so over the years, as we had more and more clinics come online, and I had to think more formally, this is just me. It's not the only way to do it. We had a discussion this morning in the executive session about, what should you do for people with other faiths? And I had this, a friend of mine from In His Image has worked at a German mission hospital, German Lutheran mission hospital in Aswan, Egypt. And I went there 6 or 7 times and helped him do some things with the residency that he built there. And in this mission hospital, I watched them have Muslim nurses and have a great relationship with the almost next door fundamentalist Muslim government-run hospital, and just seeing that amazing Christian witness that had been there for 104 years. And, I thought it's just been my personal value of like, I want Christian residents that want to go on the mission field to come. And what better way to figure out how to work in the mountains of Honduras or at the government hospital in Aswan, Egypt, than to have a colleague who's of a different faith. And so if we went through all 40 of these C4s, you'd see Bible verses through there, and then you'd eventually see Michael Jordan and Confucius and other pieces of wisdom that we pull together. And Walt Larimore has a phrase in the Saline Solution about faith flagging. I mean, that's what I'm trying to do, is just vocalize the Christian impetus for why I started the practice to begin with, but welcoming people. If you want to help us in rural Alabama, we need the help. If you want to help us in Birmingham, we need the help. So it's not the only way to do it, but it's kind of how we've been doing it. I hope I answered your question. Rambled through it. Yeah. Yes, sir. Yeah. Do you, from the perspective of being a physician that's graduating from residency and trying to open a practice, or from the perspective of like being over a network and opening another site? Yeah, I think it's gotten harder to just open a solo practice than it was even. It wasn't the easiest thing in the world in 2004. There's just a lot of different pressures now, but I think doing a market analysis and seeing if you're entering a community that needs a physician, that data is available. And one of the places is data.hrsa.gov. I mean, you can figure out, a patient panel size is anywhere from, 1,500 patients to about 3,000 patients. So if you see, like Wilcox County, there's one doctor for like 14,000 patients, there's room for you there. And you're going to be able to find patients. That's rural is not slow. You will open the doors and have people, filling up your schedule. So that's what I would suggest is, stay true to what I imagine you put. Where are you in your training? Student. Yeah, what I imagine you put in some of your statements, in your application to your professional school, medical school, I'm guessing. Stay true to that, and you'll find places in the city or in rural areas that just have an immense need for you. And there's a lot to say about the business side of it. But if there are patients there that need you, there'll be a way to take care of them. Yeah. Other questions? Okay. I think we're at time then. All right. Thank you all for coming. Yeah.